Good morning, everybody. My name is Marta Chesi. I'm an associate professor at Mayo Clinic, Arizona, and I'm here with my friends from the session we had this morning about epigenetic targeting in myeloma, as well as on mechanism of resistance of bispecific antibody. And so my colleagues here are
Larry Boyce from Emory University.
Charlotte Pawlyn from the Institute of Cancer Research and the Royal Marsden Hospital in London.
Nizar Bahlis, University of Calgary.
I think I was super excited today about hearing about the clinical development of a P300 inhibitor that I think is very important in the patient population that we are facing now that is relapsing on the current available therapy. So I think targeting P300 represent a novel mechanism of address relapsing tumor population. So how do you see, the next phase? You described today the very promising phase 2 study. How do you envision that the next phase 3 study is going to be?
So I totally agree. I think even though we've seen amazing results with immunotherapy targeting approaches, unfortunately, patients are still relapsing and we need new treatment approaches for those patients. The EP300 targeting approaches also have the benefit of largely the ones in clinical development at the moment being oral combinations, which also makes them very easy to deliver. I think we see really great data in the results that we have so far. I presented the dose optimization phase 1b study that was presented at ASH, and the phase 2 has just started to recruit now a larger cohort of people at the optimal dose selection. So really excited to start to see the data come out from that. That's a group of patients who all have to be refractory to anti-CD38, PI, pomalidomide, and exposed to BCMA targeted therapy. So these are patients with, very few clinical options, and we would expect to have a very short periods of remission. So, hopefully we will see exciting data coming from that with the Inobrodib, pomalidomide, dexamethasone combination.
No, I agree, and I think one of the things that was just exciting about this particular session was that it really focused from that we've been our backbone drugs really for almost 20 years now have been all able to target some aspect of the transcription machinery in multiple myeloma, whether it's the proteasome inhibitors and NF-kappa B, or the IMiDs or CELMoDs with the Ikaros and Aiolos, and of course dexamethasone itself through the glucocorticoid receptor. So I think this is an area clearly that is effective in myeloma, and so adding new targets here is really important. I think the P300, as you showed, it's a preferential dependency even in myeloma, so it seems like a ripe target for that. And we also heard a talk on another transcriptional regulator, IRF2, and that its potential as a target moving forward as well. So I think this is an area that I think we've all actually worked in and think that it's going to be continue to be an area of therapy in myeloma. I don't know if you have any thoughts about that, Nizar.
I was curious with Charlotte. What's interesting about the compound, it seems to be quite safe hematologically because previous P300 appeared to be quite toxic. So can you comment on that a bit?
Yeah, I mean, the main side effect are some cytopenias, but they're mostly lower grade cytopenias, and particularly at the dose that's been selected going forward.
And reversible.
Kind of slightly lower rates of thrombocytopenia and neutropenia. And clearly these are things we're very used to looking after as hematologists and very quickly reversible. So I think hopefully going forward is not too much of a kind of problem in terms of continuing dosing.
And I think, Nizar, you mentioned in your talk that one of the clear mechanism of primary resistance to T-cell engager and CAR-T is tumor burden. So I think in this new refractory patient population, I think having the P300 inhibitor, I think would represent an opportunity or try to debug the tumor before giving T-cell therapy.
Yeah, absolutely, Marta. Disease burden is one of the key factors of primary resistance to bispecific antibody. And actually, as you published very elegantly from your work in the VK-MYC mouse model, you showed very nicely that when you combine CELMoD or drugs that can target this pathway through degrading of Ikaros and Aiolos, which P300 eventually do, can dramatically sensitize VK mouse model with high disease burden to the T-cell engagers. But also perhaps, as you also showed elegantly in your work, those molecules can perhaps modify the immune environment through depleting of Tregs perhaps, or altering the immune environment to resensitize to bispecific antibody. And along those lines, I'm curious, Charlotte, do you know if P300 has any efficacy or modification on the T-cell phenotype? Have you done any work on that?
Yeah, so I haven't done any work personally on that, but I think it's a super interesting area. And as part of the phase 1 study, we're starting to combine Inobrodib with T-cell engagers in the clinic as well. So we will hopefully have some clinical data to look at that in.
And I will
soon.
answer your question, Marta, as well about debulking.
But it can also be, indirect effects, and where not P300 necessarily on the T cell, but it could be because of the response of the tumor cell that you end up inducing things like interferon responses or such that you may, in fact, still influence the immune microenvironment that way.
Yeah, absolutely. So, one of the mechanisms of cell mod that we've seen even initially with IMiD, the induction of interferon response in the myeloma cells and induction of STING. And these are important factors to allow penetration of immune cells to the tumor bed. And we've seen some dramatic responses in patients who are progressing on bispecific alone, but when we added a cell mod or even an immunomodulator like pomalidomide, these extracellular diseases tend to shrink and rapidly reduce when we added the cell mod or the IMiD in this context, likely because of the induction of interferon response in the tumor cells.
Yeah. So definitely there could be some complementary effects that you can get there than following in alterations in the immune microenvironment. And so along those lines, so you did talk, Nizar, about the tumor burden and these factors. The acquired resistance mechanisms were also fascinating and quite different than that you see in these intrinsic mechanisms. Can you talk a little bit about some of the acquired mechanisms that you see at the T-cell engagers?
Yes, so we have expanded our analysis after initial publication to a larger cohort, especially with BCMA targeting T-cell engagers, and we can confirm that the primary resistance is largely driven by disease burden, by suboptimal T-cell repertoire. By that I mean low T-cell count, in particular low CD8 effector T-cells seem to impact the outcome of these primary resistant patients. But more importantly, with patients who initially respond and acquire resistance, in this patient population resistance is dramatically driven by acquired mutation into BCMA or GPRC5D, starting GPRC5D. And these mutations eventually lead to either biallelic deletion, but more commonly monoallelic loss plus alteration in the extracellular domain of BCMA, leading to loss of binding of the bispecific antibody. And these are very common event for BCMA, more than 80% in our cohort now, which is over 40 patients. Now, there is a small subgroup of patients who do acquire resistance that are tumor intrinsic, independent of without antigenic loss, and we identifying some novel mechanism that's been known for a long time actually to be a mediator of resistance to T-cell mediated killing. One of them, for example, we observed is a upregulation of SERPINB9, a known inhibitor of granzyme B, for example. Obviously need further validation and further testing to see how often we see this event, but suggesting there are maybe some subgroup of patients where resistance could be driven by antigen-independent mechanism.
It also seems to point to the idea that granzyme B mechanism is the primary mechanism of the killing through the T-cell engager. Do you think that's also true for the CAR T-cells?
That's interesting, Larry, and we've done some work in collaboration with you actually as well, where we looked at the similar cell-mediated killing CAR T-cell versus bispecific antibody. And with CAR T-cell, actually, we do see more dependence or equal dependence on granzyme B, but also on death receptor via cell death via FAS or TRAIL, which was actually surprising to us. We didn't see that with bispecific antibody. It was predominantly driven through granzyme. So yes, for CAR T-cell, the killing is driven by soluble factors or protease, perforin, and granzyme, but also by FAS-mediated cell death or TRAIL. While with bispecific antibody, predominantly or almost exclusively driven by granzyme-mediated cell death.
But going back to the acquisition of mutation that you find in 85% of your patient population, I think I would like to advocate that clinically it should be mandatory to do at least all genome sequencing. I would say coupled with RNA sequencing of all patient population before giving T-cell redirected therapy, because these mutations are so prevalent. And I understand that often they are enriched during therapeutic pressure, but regardless, at progression it should be mandatory to do this sequencing analysis to direct the next therapy.
Yeah, I fully agree with you, Marta, especially because these therapies are first expensive economically in the healthcare system, but more importantly, they're not void of toxicities. They have side effects. So if we know if a patient doesn't have expressed BCMA or doesn't have the binding, the target has altered its binding to the target, it will be unnecessary to expose them to toxicities if they're not going to benefit from therapies. While we can offer perhaps alternate therapy like the P300, while the therapeutics available to us. So I fully agree. I would love to be able to establish a companion almost test or assay where we can clearly screen, if not by genomics, which is ideal, at least by comprehensive flow cytometry profiling to at least document the expression of the target before embarking on these therapies.
And I guess
you elegantly study in collaboration with Oli Lee that expression itself may not be enough, because you can have point mutation that specifically abolish the antigen targeted by the antibody. So,
but I guess critically important that information is clinically interpretable in the light of your other data, looking at how certain mutations do not prevent binding of all of the different BCMA targeted bispecifics. So I guess really important that we don't end up kind of clinically interpreting the presence of an individual mutation as necessarily being a contraindication to treatment. We need that kind of information to come through in those reports.
But also, again, there's different ways to target a T cell now, and so some of the types of mutations that you are seeing aren't necessarily what you're going to see with a CAR T cell either.
Exactly.
And so you also have that possibility that you can overcome some of those by using a different mechanism.
Exactly. So as Charlotte and you were mentioning, as well as Marta, these mutations are not leading to universal resistance, meaning they are often selective to one bispecific antibody, and this mutation doesn't necessarily alter response to CAR T cells, and vice versa. We rarely see mutations post-CAR T cells, at least with the current follow-up of these patients, and often these patients still respond to bispecific antibody, and vice versa. Most of the mutations identified post-bispecific antibody, at least with BCMA, tend to be retain sensitivity to CAR T cell, including ID cell and more so CILTA cell.
But so that is an interesting point, because so bispecific, 85% of mutation, not that many with CAR T, and we thought that the reason was that perhaps bispecific antibody, the way they were at least initially given, constantly keep the pressure, but then you were making the point that perhaps some of these mutations were pre-existing, so wouldn't we select them even with the CAR T? Why we don't see that many with the CAR T?
Yeah, no, that's a very good point. I don't necessarily believe that all mutations are pre-existing. Some of them, perhaps a small proportion, may be pre-existing. But going back to the CAR T cell, now that we're seeing relapse late in some of these CAR T cell therapy after 3 years or 4 years in long-term responders, we are seeing actually mutation in those patients because of CAR T cell persistence.
So we were focusing on that earlier, that is almost like an initial failure of control the tumor and not really capturing the true relapse. So this is very interesting.
And the initial failure likely because of the suboptimal CAR T cell product as well. But now we're seeing those late relapses. Again, numbers are small, but at least the last 3 patients I've sequenced with late CAR T cell relapse for 3 years, all of them had BCMA mutations.
Oh, that's very interesting. You should publish it soon.
Well, no numbers, we need to expect.
Well, if we want to finish with mutation, any built-in correlative study in the trial you're conducted with P300 to already get a signal of mechanism of resistance to P300 inhibition?
Yeah, so there were several ongoing correlative studies looking to try and understand, why patients are relapsing within the study. But no data that I'm aware of yet.
Well, stay tuned.
Along those lines, the P300 mutation is being reported even in the initial COMPASS data set. Do you know if any of these mutations alter the activity of the P300 inhibitors?
It's a really good question, actually. We looked in our data set originally from the Myeloma 11 trial at mutations and reported mutations in AP300. I don't know the answer.
I wonder if these are activating mutation, perhaps, not necessarily inhibiting mutation.
That's a good question.
Yeah.
But I would like to conclude saying that as a bench scientist, for the long time, we thought that all the myeloma therapy were empiric and we really needed a Gleevec in myeloma, no targeted therapy in myeloma, maybe venetoclax. But I would say after the session today, I think we can conclude that actually myeloma perhaps is the prototype example of targeted therapy in cancer, with all this therapy converging on the super enhancer.
Very well said.
Do you agree? Now you.
I agree.
Yeah. Okay.
I agree. I think there are some differences. Gleevec targets a translocation, where
Yes.
these are actually targeting functional dependencies of
Yeah.
the cell, and so I think that's where what really sets myeloma apart, is that we're not necessarily targeting the
Oncogenic event.
mutations,
Yes.
but targeting these dependencies that were determined as functional.
That
ones.
mostly are actually plasma cell dependency more than myeloma dependency.
Many of them
I want to thank the member of this session for a very engaging
Thank
and
you, Marta.
stimulating
Thank you, Larry.
conversation, and I can't wait to meet again next year to hear the next development.
Thank you.
Thank you.